At last count, the United States spends 18.4% of our GDP on health care. It has all sorts of impacts. First of all, average family spends $22,000 a year on employer-sponsored health care plans. And we just have to look at what's happening to the fiscal health of the federal government to see the consequence of uncontrolled health care costs. Dr. Maddox, recently I was reading something from a physician who said that he had this reoccurring dream that someone was throwing eggs over the top of a building, from the top of a building, and his job was to try to catch the eggs, when he realized the best way to stop the eggs from hitting the ground was to go up and stop the person from throwing the eggs over the top. I know that's kind of a funny way to talk about the fact that our healthcare system is really a sick care system. And just for example, adult onset diabetes causes hundreds of billions of dollars in excess healthcare costs because people simply do not control their weight and exercise. Maybe it's not that simple, but those are certainly components of it. What do we need to do to not only save money, but to provide better outcomes for the American healthcare system? The OECD, the Organization for Economic Cooperation and Development, 38 of the most advanced democracies and economies in the country, in the world, they spend half of their GDP on average with what the United States does. So how do we fix that?
That's a great question and a fascinating analogy. And as a cardiologist, I support the diet and exercise, and I'm not sure how I feel about all the eggs, but very much appreciate the question. You know, I think the difference between many other countries and ours is the degree to which we focus on prevention, long-term outcomes, and to my colleague's point, to really invest in primary care. We have a system that pays more to do more, and not a system that pays more to keep people healthy. And until we change the payment structures to reward insurers, providers, all of the parts of the healthcare system for keeping people healthy, we will continue to pay for sick care.
So we need to follow the money.
That's a complicated fix. This is very baked into how we do things, but that we need to invest very differently in healthcare.
Well, it's really hard to unravel who gets paid for what in the healthcare system. It seems to me the complexity is not a bug, it's a feature of our system, and I don't think it's an accident. People have figured out what the system is and how to maximize their return, and that's why you see so many big players get involved. That's why you see the consolidation. That's why you see so many other features that we're talking about here today. But Mr. Martin, your group's membership has played a critical role in things like care coordination efforts and looking at sustainable value-based payment models. I remember us talking during the Affordable Care Act debate about trying to pilot ways to pay doctors to help keep their patients healthy as opposed to just treating them after they got sick. Are there any viable payment models now that would actually work, that would both improve patient outcomes and reduce the amount of money that they have to pay?
Well, thank you, Senator. I think there are a number of innovative models that are being explored, and some have demonstrated efficacy that is greater than others. I think in total, the innovation in primary care is in its infancy of determining what the right approach would be. I think there are two things that I would suggest to you. One is the traditional fee-for-service construct is probably not congruent with the types of primary care and prevention in the healthcare system that prevents the eggs from coming over the edge of the building. We need to create greater investment in a more prospective global perspective to really support primary care in all settings.
Well, if you'll help us figure out how to do that, I would be very interested.
I'll jump over I'm ready to go today.
Well, and I wonder, Dr. Maddox, I mean, do they even teach this in medical school?
They actually don't teach the payment part in medical school, Senator. We learn a lot about the doctoring part and then get out into the real world and realize that there's a whole lot more to it. And I think that actually might be why private equity and corporatization and consolidation has had such a fertile ground to go into, because doctors don't come out of medical school wanting to deal with this stuff. We want to help people manage their diabetes and their obesity and their hypertension, not argue with an insurance company about whether something's covered. So I think you've sort of hit the nail on the head there.
Well, Mr. Chairman, it seems like if we're going to try to attack the excessive cost, the percentage of our GDP, the amount of money that families have to pay for health insurance premiums, that we're going to have to not only look at the consolidation issues and the transparency issues, but also how we actually compensate physicians and healthcare providers for treating people, and how do we keep them healthier rather than just treating them after they develop chronic diseases.
I would just say to my colleague, you got me at hello on this, because there's no question that this is a sick care system, that prevention gets the short end of the stick. And finally, after years' worth of effort, this committee was one of the leaders in the effort to finally get an annual wellness visit into Medicare, which was a start towards the kind of prevention ethic you're talking about. But I look forward to working very closely with you on it. Okay, Senator Cantwell.
Thank you, Mr. Chairman, and thank you